as much as I talked about with the valvular diseases, don't even entertain looking at valvular diseases if you don't know the blood flow through a normal heart. In this case, don't even look at congenital heart diseases if you don't know the normal fetal circulation. Okay? So let me just talk to you about fetal circulation very briefly, why we make a big stinker about this. In the fetus, and then it'll make sense what we're going to talk about here. In the fetus, blood is coming from the placenta to go to the fetus. Now, two things we have to bypass. The blood coming from mom, going through the placenta to the baby, the blood there has all the nutrients have already been detoxified because that blood has already gone through mom's liver. The liver in the fetus is still developing. We have it there. Blood will go to the liver just to give it nutrients, but the blood in the liver is not going to be detoxified. The liver is not functioning. So we have to have a setup that's going to bypass the fetal liver because it's just not going to detoxify anything. And anyway, the blood that's coming from mom is already detoxified. Now, the other thing that has to bypass is the fetal lungs. The lungs, well, they're still developing the fetus. There isn't any oxygen that's really coming into the baby's mouth. It's inside an amniotic sac. So the lungs, blood still has to go to the lungs just to give it nutrients, just the tissue itself. But for the function of the lungs, it's useless to go over there. Well, it doesn't matter because the blood that comes from mom has already been through mom's lungs. So now the blood that's coming through the placenta is already detoxified from mom's liver and already oxygenated from mom's lungs. It's perfect. Right, it's all done. So we have to have a system that's going to bypass the fetal liver and bypass the fetal lungs. And that's what makes it a little bit different. The other thing, too, that kind of drives people nuts is that the blood that's coming into the fetal heart is reversed, meaning that the right heart is going to accept oxygenated blood, and the left heart is going to accept deoxygenated blood. Now, think of the reason why. If we're bypassing blood going to the lungs, then how much blood is going to come from the lungs into the left heart? Little, if anything, right? So the pressure in the left heart is going to be much lower than the pressure in the right heart. Okay? The pressure in the right heart is going to be massive because it's coming from the placenta. So we got to somehow, and that's where it gets a little confusing. That's why you have to look at it and understand the fetal circulation. You have to somehow get blood from the right side onto the left side so that it can go into the aorta. So we have a lot of different things. There's a hole in the heart called the foraminal valley that goes from, blood goes from the right atrium to the left atrium. If that's correct. You're starting to understand all that, right? So again, make sure you know the blood flow through an adult heart, and then also understand blood flow through the fetal circulation. Now, if you go through the first 50 slides of my PowerPoint, I do have about 5 or 6 slides explaining the whole fetal circulation. I got wonderful schematic pictures to show you all that. Then what happens is when the baby comes out, things will change. As soon as the baby comes out, we cut the umbilical cord. So now there's less pressure coming into the right heart. And also, the first thing the baby's going to do is what? Cry. And those lungs fill up with blood. So now there's going to be a ton of blood coming from the lungs into the left heart. And it goes back with what you're used to seeing. But if those changes, if that foraminal valley does not close, if the ductus arteriosus does not close, all these different bypasses, we're going to have problems. And that's what this is all about. When they say a hole in the heart, that there's an atrial septal defect, that's all about this. But this thing I showed you to before on the internet, on fetal circulation. There's a wonderful thing I showed you to before on the internet on how to understand all that. It shouldn't take long. It should take about maybe a half an hour to go through that, but there are things, and read my first 50 slides or so, but I think it's the last part. It's only like 5 or 6 slides. So let's talk about congenital heart diseases. It happens in about 1% of births, and you have these cardiac malformations that occur in the first 3 to 8 weeks of gestation inside the mother's womb, okay? And the most common cause of why you're getting these birth defects is Down syndrome. The most common cause of this. There's other things, like certain viruses will do this. Rubella is also notorious for causing cardiac malformations. Fetal alcohol syndrome, when a mother's drinking a lot of alcohol during pregnancy, right? And gestational diabetes will also do this too. There's other reasons also, but these are the big ones that you should know, okay? Now we have 2 general categories that go into these congenital heart disease. It's either something to do with a cardiac shunt, so blood is being diverted from one side of the heart to the other side, okay? Or there's going to be some kind of cardiac obstruction that's pressing against something where the blood flow can't get through, okay? So let's talk about the shunts first. Now this is when the baby comes out, so we're not talking about while the fetus is inside the mother. Once the umbilical cord is cut off, what's happening here? So we have something called a left to right shunt. This is where the blood, oxygenated blood, is going to go, once the baby's born now, it's going to go from the left heart to the right heart. So you're going to have oxygenated blood going from the left heart, and somehow it's getting shunted to the right heart, when it should be going into the aorta to give perfusion to all the other places. Now, most of it will go that way, but you will have some going into the right heart, which means it's going to go back into the lungs, which it doesn't need to do. Okay? If it's not corrected, it can cause irreversible pulmonary hypertension, because the lungs are just getting too much blood from now this right side of the heart is pushing more blood over there. So it's going to need some kind of heart or lung transplant. Okay? When this happens, the person, the child is not going to be blue. Okay? There is things happen. We'll talk about the different side effects on here, or the symptoms. But one of the things is that they won't be blue. The color blue that we're concerned about is something called cyan. Cyan, S-Y-A-N, is a color blue. If someone's blue, they're out in the cold, they're turning blue. So we call this acyanotic. A meaning without, cyan blueness. Okay? So in these cases, when you have an atrial septal defect, a ventricular septal defect, a so-called hole in the heart, okay, or something we call patent ductus arteriosus, they will not be blue. They'll be acyanotic. Okay? Then we have a right to left shunt. In this case, deoxygenated blood is somehow being shunted into the left heart, from the right heart to the left heart. This is very bad. Okay? So in a case like this, they will become cyanotic because you're putting deoxygenated blood into the left heart, which is then going to go into the aorta, so you're getting a lot of deoxygenated blood into your lips, into your hands, and so forth, and they will appear blue because there's less oxygen in that area. So we have Tetralogy of Fallot and something called Transposition of the great vessels. We'll talk about those. So those are our 2 shunts, left to right shunt, right to left shunt. But we can also have some sort of obstruction to the blood flow in the circulation. So if a blood vessel is unable to expand because something is blocking it, okay? When you have something like, if this is your aorta over here that normally will go this way, but let's say there's something over here that's going to press against it. Now what will happen is it'll do this kind of picture. So something blocking over here, it's going to get obstructed. Does that make sense? Okay? And the blood is going to have problems going that way. So we have one that I want you to know is called coarctation of the aorta. Okay? So what we're going to do is talk about these 3 and then these 3 over here. And I have one slide for each one. I got a picture for each one, so it makes your life easier. But again, it'll make your life so much easier once you understand circulation of the fetus So we'll take place of that. Okay? So let's talk about this one first. The atrial septal defect. What this means is that there's an opening, a connection, a shunt between the right atrium and the left atrium. So let's show you what actually is happening over here. Okay. So this is our heart, and we have the 4 chambers, and we have the right atrium, left atrium, right ventricle, left ventricle. We have this atrial septum over here, right? The interatrial septum. Now, normally, this is what's happening. In the fetus, we have it set up like this. There's an opening here. Now, in the fetus, keep in mind, blood is going to pour into the right atrium and it'll be oxygenated blood. It's the reverse of what we expected. Okay? That's okay. So what will happen here is that there isn't much blood entering the left atrium because the lungs are not getting that much blood. Again, this is the fetal circulation. So we have an opening here. This is called the foramen ovale, right? Foramen ovale. And blood is going to, oxygenated blood is going to go from the right atrium to the left atrium. This oxygenated blood will go into the left ventricle, into the aorta. Works perfectly. And we did this, and we also bypass it. So blood, very little blood goes to the right ventricle. See? So we're bypassing the lungs. Okay? We have this little foramen ovale. Now, when the baby wakes up, or not wakes up, but gets delivered, we cut the umbilical cord, so that means there's less blood going into the right atrium. So the pressure is going to be higher here than over here because the baby's going to start crying, like, you know, open up its chest, and all of a sudden blood is going to be all going into the lungs. So now there's going to be a lot of blood entering the left atrium. Does that make sense? So instead of high pressure here and low pressure here, we got high pressure here and low pressure here. This opening is going to close. Now it's not a foramen anymore. It's not a hole. It's now a depression, and we now call it a fossa ovalis. And this you can see in an adult heart. It's a very thin area.
And that will happen immediately?
Mm-hmm. And it'll fuse like in a few weeks. Yeah, but no blood can go back the other way.
So when there's another defect, that will happen?
That'll happen with everybody, okay? That's what happens normally. Now, in an atrial septal defect, this closes, but it doesn't close properly.
So one wouldn't know that it's closed properly, not for a little bit.
Well, that's why they've got to listen to the heart to make sure there's no hole there.
But that's a week after the baby is born.
No, just when the baby's, that's why pediatricians, I mean, their hearts are racing. I couldn't, you would hear a murmur. I can't hear. So if you listen to enough of these, if a pediatrician hears enough of these, hearts that's beating that fast, he'll or she will hear a little murmuring. If there's a question about it, we'll do an echocardiogram, and then we'll see if there's a hole there. Because what will happen is, if there's an opening there, you're going to have blood that's going to mix. And that's what's happening over here. All right? That's an atrial septal defect. Okay? Questions on that? All right, so that's what that is. Now, the other one is a ventricular septal defect. This is the most common congenital malformation in the heart. Okay? And in this case, it's a little bit easier to understand, but what happens here is that this ventricle, the way it forms is that there's a little bud that goes here, and a little bud that goes over here, and they kind of go down here and up here, and they kind of fuse together. Oh, yeah, absolutely, I'm sorry. Yeah, so this is closed now. All right, we're just talking about, okay? But here, it kind of fuses that way. If it doesn't close all the way, then what's going to happen here is that there's going to be a connection between the two. And that's a ventricular septal defect. That's the more common one. That will usually fuse on its own. It depends on how severe the hole is. Or they'll just put a little plug there. And they'll close it up that way. If it's really massively big, they'll do major surgery. I mean, put a plug there. That is still surgery. Okay? Sound good so far? Okay. Those are the easier of all of them to understand. So let's do this one. Okay? This is called a PDA, a patent ductus arteriosus. A ductus arteriosus is also going to help bypass blood from entering the fetal lungs. So we had one thing with the foraminal valley I showed you. But what about any blood that normally would go into the, most of it will go this way. I don't know percentage. Let's say 70% will go this way, but another, let's say 30% will go this way. You don't want it to go into the lungs. So now we have this. Now, this is what happens normally. Okay, let's say this is a fetus. Okay, so what happens here is that if blood goes into the right ventricle, it's going to go into the pulmonary arteries, and normally it's going to go through this little patent arteriosus. So disregard the arrows for now. I'm just trying to, once you learn fetal circulation, it'll make more sense. But normally you'll have oxygenated blood going here, very little amount. It'll go through the pulmonary arteries and go through this little ductus arteriosus, and it'll go into the aorta. So what will happen here is that and I'll draw it, normally in a fetus, it'll go through here. So the oxygenated blood, 70% goes this way, goes right into the aorta. The other 30% will go this way, but because you have this little ductus arteriosus, that'll also go in the aorta. You see how it's all put together? Well, this should close at the time of birth. If it doesn't close, we have a problem. Because now blood will go, well, that's what I want to show you. All right? Oops, sorry. So what will happen is, now let's show this now as though this is now a baby that was just born. We cut the umbilical cord, the babies took a deep breath. There's a lot of changes. When you do the fetal circulation and read it, there's bypasses you need to know in fetal circulation, but as soon as you cut the umbilical cord, you got to know all these changes. Like the foraminal valley became the fossovallus. There's changes, like the ductus arteriosus will close. Okay. And it turns into the ductus ligamentum arteriosum. So what happens here is that if this doesn't close properly, so now what will happen is blood now in a child, blood will normally go from the right ventricle into the lungs. That's normal. But now oxygenated blood is going to go from the left ventricle into the aorta, go down the descending aorta, but some of it is going to go into this patent ductus arteriosus. Patent means open. All right, stays open, stays patent. And that's going to also go into the lungs. You see?
Go into the lungs twice.
Correct. So what will happen is the lungs are starting to fill up with more blood. So you're going to increase the blood to the lungs. Well, no, because this is now, right,
Recycled blood.
it's not, because now we're talking about the baby's born. So the blood that's coming in here is deoxygenated, right? We needed the ductus arteriosus there in the fetus because oxygenated blood is coming on the right side.
It was opposite, it's reversed.
Right. So now once the baby's born, now all this is deoxygenated blood. So now you're going to have deoxygenated blood going into the lungs to get oxygenated, but you're going to have oxygenated blood here, which is going to also go back
Do
into...
you always have that?
What do you mean?
So your arm's always there.
No, it closes up. That's what I said.
Then your oxygenated blood gets oxygenated again.
Right. No, it doesn't get, it caps off. It's 100%.
Because it's already.
But you're putting more blood into the lungs. That's not good. So now you're going to increase blood into the lungs. You're going to increase blood to the left heart. So it's going to, more blood go, so the pulmonary, so the left atrium is going to have more blood to go into. That's going to increase the workload to the left heart, which means the left ventricle is going to get more blood in there. It's got to push more blood out. So you're going to see hypertrophy to that. Like this chamber is going to, if it's normally supposed to get like this, well, now it's going to be smaller, right? Because all this muscle mass, right? Not the septal defects, but what will happen is muscle mass is growing this way, but it's also growing that way. So now your cavity is going to get smaller. And if that cavity gets smaller, the left ventricle cavity is getting smaller, you're going to decrease your cardiac output. Does that make sense?
Yeah.
You need this during fetal circulation. You don't need it afterwards.
Okay.
Flip it.
So then what happens? So if you decrease cardiac output, could that lead to death? Could the baby die?
Yeah. Oh yeah. Yeah. That's too much. It's too much. Yeah. You'll have pulmonary congestion. Yeah. It's too much.
The baby would die.
Mm-hmm.
If
So
you
we
don't-
got to close
if you don't
this. That's all you got to do is
catch it-
close
If you
this.
don't catch it early enough, the baby
Right.
would die.
So what it is that prostaglandins keeps this open. Okay. Right. So this is always open during. Prostaglandins will always do that. A prostaglandin inhibitor will close it. Give me an example. I know that we're not going to do pharmacology, but give me an example of a prostaglandin inhibitor. Aspirin. So now think about this. In a woman who's pregnant, do you see why you don't give a woman who's pregnant aspirin? What will happen? It'll close it. So that's why they say give aspirin to a pregnant woman to cause heart defects. Now you know which heart defect. But when you talk to a patient who doesn't know all this, just say it causes heart defects. You know what it is. So if a person has a patent ductus arteriosus, when the baby's born, do you know what we give in IV? Some sort of, well, I wouldn't say aspirin, but something of a prostaglandin inhibitor. Cytotec. There's certain things that we could give. Does that make sense?
Yeah.
And hopefully that closes it. If it doesn't, they have to do surgery. I wouldn't ask you about the aspirin stuff, but I want you to, I always like to put pharmacology, but I don't want to put it in because students complain I'm turning to pharmacology, but I want you to understand why this stuff's important, the significance here. All right? So does that make sense? It's kind of fun, but it makes more sense if you know fetal circulation. Yeah. Okay, so that's patent ductus arteriosus. Now, this one's Tetralogy of Fallot. Ooh. I'm going to keep this short and brief because it'll make more sense once you understand fetal circulation. Tetralogy, the T-E-T-H-A, that's an abbreviation or at least a prefix for 4. So there's 4 features that happen here. There's 4 defects. So this picture actually kind of shows everything. One of the things it does is that you have an interventricular septal defect. You will have that connection over there. That's one of the features. Another feature is that you get pulmonic valve stenosis. So the pulmonary valve, which is over here, is stenosed. Okay? The other thing, kind of a weird thing, is that the aorta is going to override where the septal defect is, the ventricular septal defect is. In other words, it's right over both the right ventricle and left ventricle. So you're going to have both deoxygenated and oxygenated blood going into there. Into the aorta. Does that make sense? Okay? And the other thing that happens is because there's a backup of blood over here because of the pulmonary stenosis, this muscle, this right ventricle, is going to be hypertrophied. Because it's now it's trying to push blood through that pulmonary stenosis, that valve that's now stenosed. So you're going to have the right ventricular hypertrophy because of that. So those are the four things that happen in there. Busy, but you can almost say, like, you know, which of the following is not part of Tetralogy of Fallot, A, B, C, D, E? You can almost guess like there's a possible question, right? Okay, so that's what the Tetralogy of Fallot is. They will have questions on the NCLEX, I guarantee that, okay? All right, and then we have transposition of the great vessels. This is another weird one, okay? And it's just what you say. You have two great vessels, the aorta and the pulmonary trunk, or pulmonary arteries. They just get reversed. It's a weird thing. So in other words, the aorta is connected to the right ventricle, and the pulmonary artery is connected to the left ventricle. Yeah, it's just transposition. So this is what normally happens. Here's your right ventricle going to the pulmonary artery. Here's the left ventricle that's going to go to the aorta. Now they reverse. Yeah. So you have the right ventricle pumping deoxygenated blood into the aorta. You see that's bad? And you have oxygenated blood that's going to go into the pulmonary. So this is one that's incompatible with life.
Incompatible with life.
Incompatible, and it's impossible. However, the survivors, how do you explain that? How do you have somebody who has this that's born this way? Because the only way it would work is that there's got to be some sort of shunt going on. There's got to be some sort of interventricular septum, so that some of the blood going from the left ventricle is going into the right and vice versa. So that if there is a survivor, it's got to have some sort of atrial septal defect or ventricular septal defect.
So it's either not going to fuse in the ventricles or it won't fuse in the
Right.
Okay.
If you don't have that, it's incompatible with life. This would work okay inside the fetus because oxygenated blood is going to enter the right heart, which means it's going to go right into the aorta. So in the fetus, it would be fine.
But once they're born.
Once they're born, no.
No.
So questions about that one? That's a little bit of a weird one too, okay? Then we have coarctation of the aorta. And what that is that there's going to be some kind of constriction going around the aorta. See it? See right there? All right? Now this is an interesting one too. Usually that constriction happens distal to the aortic arch, where you got these three major branches coming off. Remember the brachiocephalic, the left common carotid artery, and the left subclavian. This is all giving blood flow to the arms and to the head and to the chest. Beyond that, it's going to go to the below the diaphragm. So look what's going to happen here. Blood flow to the arms and to the head is, well, it might be higher because you have a backflow of blood over here. So it can't, that's basically a stenosis. So there's going to be high blood pressure here, but what about the blood pressure that's distal to this? Decrease. So if you take blood pressure in the arm, is it going to be high or low? If you take blood pressure in the leg, is it going to be high or low? Different. So that's why high blood pressure in the arms, low, so they would do that. But it makes sense. That's why I'm saying, don't memorize. Understand the concept. But you need to know the anatomy of this from A and P too, to see what these blood vessels go to. But it puts it all together. It's interesting. I mean, you could, there's a lot of nurses that want to just do this kind of stuff prenatal. This is a lot of interesting stuff.
Which I feel like it's interesting too, because I feel like a lot of times with babies, we take it on the leg because it's just easier. Like a blood pressure on a leg is easier on a baby because they're so apt to want to put their hands towards their face and stuff. So if you did this,
Well, you do the blood pressure first in the arm, and if you see it very high, then they're going to want to see the blood pressure. And then you got well, I wouldn't say the instant answer to that, but you definitely have a direction.
Would you do 4 points then at that?
Sure.
Maybe.
Because there's other things where this will be high and this will be low.
Oh, yeah.
Because you could have a constriction that happens over here.
Okay.
And if that's so, this brachiocephalic gives blood supply to the right arm and the right side of the head.
So your right
So
arm
your
would be
right
higher,
side will,
but the left
exactly.
side would be lower.
See?
But then the legs would still be
Low.
Okay.
Mm-hmm.
Okay.
Does that make sense?
Yes.
Okay.